Should I?
Okay, so I'm going to introduce you.
Okay.
Welcome everybody that's here. Today we have Dr. Ilene Ruhoy, and she's going to be talking about headaches and MECFS, and I'm just going to read her bio. She is a MD, Ph.D, and a board-certified neurologist in private practice in Seattle, Washington. She specializes in chronic and complex illness and is also the medical director for the Chiari EDS Center at Mount Sinai South Nassau Hospital. Originally from New York City, she received her MD at the University of Pittsburgh and trained in both pediatric and adult neurology at the University of Washington and Seattle Children's Hospital with fellowship training in neuromuscular medicine and a focus on mitochondrial disease. She is also a graduate of the University of Arizona Integrative Medicine Fellowship. Her PhD is in environmental toxicity from the University of Nevada. She has authored and co-authored multiple publications and is also the co-editor of Integrative Neurology, published by Oxford Press in July 2020, and the co-editor of Preventative Neurology, issue of Seminars in Neurology published by the
They're German
Press in November 2022.
Yay.
Dr. Ruhoy also serves on several boards for both medical organizations and health wellness companies. And with that, I'm going to turn it over to you. And if everybody could just be sure to mute yourselves.
Well, thank you, Melinda. It's really nice to be here. I'm honored that I was invited, and there's so much to talk about when it comes to MECFS, but I'm going to focus on headache, which I was saying earlier, headache itself for a neurologist is a very, very big topic. And, in fact, there are subspecialists that are headache specialists. So, and it's because there's so many different reasons for headaches, including within the MECFS population. So I'm going to just sort of go through a general overview of headaches in MECFS, and I'm happy to take any questions that are more specific to help direct my information so that I know that I'm answering the questions that you may have in your head. So I'm going to share my screen. Let's see how best to do this. Is it PowerPoint, I guess? Not allowing me to share. Is there a reason?
Oh,
You're muted. You're muted, Melinda.
how's your day, mate?
Yeah, good.
Productive.
How
I
was yours?
have it set up for you to be able to share your
This what?
Nice and steady.
Oh.
I've just used it. So I'm really bored.
Okay. Oh, I see. I think it's on my side, actually. Okay. I think I have to allow.
If everyone who's listening can please mute, that would be really helpful. Thank you.
It looks like it's gonna quit and reopen. It looks like it's gonna pull me out of the meeting so I could reopen this so I could share the screen.
I'm trying to switch it to active speaker too, and I'm not able to do that. Thank you all for being here.
Okay. Now it should allow me to share. Yep, there we go. Here we go. Okay. Okay. So open this. Okay, can everyone see my screen?
Yes,
Okay.
we can see it.
Okay, so let's get started. So headache and MECFS. Thank you, Melinda, for introducing me. I have no disclosures. So a little bit about MECFS. So what is now currently the National Academy of Medicine, but used to be called the Institute of Medicine, in 2015 had proposed diagnostic criteria for MECFS, and it largely focused on 3 symptoms, which was 1, a substantial reduction or impairment in the ability to engage in pre-illness levels of occupational, educational, social, personal activities that persisted for 6 months and is accompanied by profound fatigue, which is new, but not the result of overexerting or and is not alleviated by rest. And then they added post-exertional malaise, which there's some overlap between number 1 and number 2. So with MECFS, minimal exertion creates an overwhelming sense of Have I been muted this whole time? Oh, so you hear me because I just got a message that I need to be unmuted. Okay. And then at least one of the 2 manifestations of cognitive impairment or orthostatic intolerance, which is usually a POTS-like presentation, but there's often blood pressure lability. So POTS, of course, is with movement, with standing upright, you have an elevation of your heart rate without significant change of your blood pressure, but it's not only when standing, POTS can present an orthostatic intolerance or orthostatic hypotension can present even when just standing for periods of time or even walking for periods of time. So they added these 2 things, but I will say that I have never seen an MECFS patient without all of these things. So it's very easy to make this diagnosis for the most part. I think the key, of course, is that it has to be, these symptoms have had to have gone on for 6 months, and there had to been there's no other reason for it, I guess, is the point, which is sort of what the CDC said. The CDC noted that there had to be no other reason for all of these symptoms. And that's what the important point they made. They had also added things like, cervical lymph nodes that were tender and enlarged, and they had some other symptoms. And in fact, they now have handouts that you could sort of download, and I put the link here. Could you have MECFS? And I often give that to patients if they're wondering if MECFS is a diagnosis that would apply to them. And they have a toolkit even for physicians about how to help patients decide if that's their diagnosis, and if so, where you can go from there. And what's interesting is that in the Institute of Medicine in 2015, they noted that millions of Americans were suffering from a diagnosis of MECFS, even though clearly millions of Americans weren't being given that diagnosis. And they noted that 90% of those that had MECFS had not been diagnosed by their doctors, and yet it was costing the U.S. a ton of money by loss of productivity, of course, and because these patients obviously cannot hold full-time jobs, it's been very difficult. My office has spent a lot of time filling out different disability forms because of this disabling fatigue and cognitive impairment and difficulty sleeping and post-exertional malaise and prolonged recovery from even minimal exertion. Obviously, they can't do many jobs, and they couldn't hold, certainly not full-time jobs. And so we tried very hard to get them disability, which is really an uphill battle. A lot of disability insurance companies don't want to pay for it. And it's a very heterogeneous disease. And so I think it's one of the reasons why it's been somewhat controversial over the years, and also why a lot of doctors don't really understand it. And hence that's why they don't make the diagnosis, and hence why they don't treat it. So it's really been an uphill battle. I will say that now in the day and age of long COVID, I think there's a lot of discussion with regards to whether long COVID is MECFS. And I think that's actually a good conversation and probably a separate dialogue, because there are some distinctions, frankly, between the 2. But if you just look at the basic criteria from which the Institute of Medicine and even the CDC point out, which is sort of this disabling, profound fatigue, from any minimal exertion, certainly that applies to long COVID patients as well. So I think that this idea of MECFS is now a little bit more on the radar for mainstream medicine, although not clearly enough for sure. So patients with MECFS, as I said, they very rarely only present with one or two symptoms. And in fact, I think I'm sure this audience has heard before, we talk about the septad patient. It used to be the pentad patient. Now it's the septad patient. Now we're thinking it's more like the dectad. I don't know. I can't figure out what to call it, but there's lots of different symptoms. So I listed 8 here, so that's not technically septad, but it's octad, I guess. But of course, there's mast cell activation syndrome, and these are important because they can all in their own way contribute to headaches. So mast cell activation syndrome, POTS, connective tissue dysfunction, GI involvement, pain, lots of pain, autoimmunity, genital urinary involvement, and of course headaches, which I'm going to focus on for the rest of the talk. But know that there's like, you can consider these Venn diagrams, they're all overlapping. And they all in some way contribute to the other. And that's why we think we see this present as such a constellation of symptoms and a constellation of diagnoses. And obviously it's not a good thing because these are a lot of different symptoms and really contributes to a whole host of suffering for the patient. But for physicians, sometimes it gives us a roadmap, right? It gives us a roadmap of what we can start looking at and what we can start treating. So MECFS and headaches. So there actually has been, interestingly, studies on headaches and migraines in the MECFS population, despite how controversial MECFS has been, right? Which is was interesting to me when I first looked up headache several years ago. People were looking at headaches in MECFS patients. So in fact, they found both migraine with aura. So an aura is usually, the most common aura is a visual type with these zigzag flashing lights, or a scotoma, which is sort of this central blurry vision or even a blind spot. But there are lots of other auras that can be tingling or cognitive and function, or even migraine without aura are more prevalent in MECFS patients than in patients without MECFS. And in 2002, a study found that 67% of migraine patients met the CDC criteria for CFS. So, migraine diagnosis is given all over the place. It's often erroneous because there are quite a few headaches. There's many different headache syndromes. There's many different headache types. And in fact, there are headache classifications that are, 15 pages long, but yet most doctors will just say that's migraine. So not everything is migrainous. And we, from all the research done in migraine, I have to say that migraine is a very specific kind of pathophysiology. So I think migraine diagnoses are just sort of given out. So, but regardless, they took a lot of migraine patients and they found that the vast majority of them met the CDC criteria for CFS. So, so that's interesting that, is it the chicken and egg? Is it the migraine that comes first and the CFS follows, or is it the other way around? And then in 2015, a study found there was an increased risk of CFS in migraineurs. I get often asked the question of, do I have MECFS? With patients with other kinds of symptoms. And I always think that there are risk factors for CFS. I don't think MECFS is a primary diagnosis per se. I think it eventually seems to become one, but I think that there are certain things that put patients at risk of developing MECFS. Of course, the obvious one is hypermobility, which we'll talk a little bit about. But it was interesting that in this study, these doctors actually decided to take a bunch of migraineurs and see if they were at increased risk of CFS, and they found that they definitively were. So, and then in 2006, they found that there was a 4-to-1 female to male ratio in chronic fatigue syndrome. And what's interesting is there's an overlap of fibromyalgia syndrome and chronic fatigue syndromes. And of course, we know that most fibromyalgia diagnoses are given in females. The majority of fibromyalgia patients are females. In 2020, there was a study that found that in females with diagnoses of both fibromyalgia syndrome and chronic fatigue syndrome, they had systemic hyperalgesia, which meant that there was just more pain everywhere, right? So not only headache pain, but their bodies, they felt more pain than you would otherwise expect. So the pain perception was disproportionate to whatever the injury might be. And it might not even be an external injury. It could just sort of be like a neuroinflammatory injury or an inflammatory injury. And it's usually related to the small fibers, the nociceptors. So their nociceptors fired a lot more than in patients without these diagnoses of fibromyalgia and chronic fatigue. So they just felt more pain overall in their bodies. In fact, there's a greater incidence of chronic regional pain syndrome in CFS. So again, and central desensitization. So just feeling more pain. And then there are increased migraines in patients with fibromyalgia syndrome as well. So not only in chronic fatigue, but in fibromyalgia. And again, there's an overlap between FMS and CFS. And patients suffering from migraine and FMS had lower quality of life scores and higher levels of mental distress. And a higher incidence of FMS was found among female migraine patients, but not in males. So again, speaking to the prevalence of these diagnoses in the female population, which of course leads to the whole gender bias in medicine, which is a whole other topic, of course. But and I think that while I think these diagnoses are real, I do believe that they probably occur as well in men, maybe not as often, but they do occur in a higher incidence in men that are being recognized. But of course, men's symptoms are taken a lot more seriously and they get a lot more workup and they just sort of are treated differently and they're not given these diagnoses, which, 10 years ago, I once heard a male physician say fibromyalgia was a wastebasket diagnosis. And so I'm not even sure what that means, really. But it does speak to the, again, the gender gap in the gender bias in medicine. But of course, these patients have lower quality of life scores and higher levels of mental distress, because not only did they have increased incidence and perception of pain, but they, their doctors weren't taking them seriously. They weren't getting appropriate treatment. And of course, that contributes to lower quality of life. They weren't able to interact as well with their families, their friends, socially, academically, occupationally. They couldn't engage as they had been prior to the symptom onset. So clearly their life was different. And again, there's been a very valid association between small fiber neuropathy and fibromyalgia syndrome. And in fact, for years, we've known that about 40%. In fact, I think I saw a recent study that actually states that it was higher, but 40% of fibromyalgia patients had positive skin biopsy for small fiber neuropathy. So a skin biopsy is what's called the gold standard, sort of the way of diagnosing small fiber neuropathy. I mean, it's got some very classic symptoms, in terms of pain, basically, that is usually multifocal, so it could be patchy, because the small fibers are sort of everywhere, and there are these abnormal, they're not very well differentiated nociceptor C fibers, and they feel inflammatory pain is what they feel, is the best way I describe them to patients. And so it's usually multifocal or diffuse, right? So the large fibers, which are more classic peripheral neuropathy fibers, which you can pick up on a nerve conduction study. The small fibers are not picked up on any kind of electrodiagnostic testing. The large fibers can be. Those are usually, though not always, length dependent. So start in the feet and then move up to the knees, and then you feel it in the hands, and then they continue to ascend. But the small fibers are undifferentiated and are just sort of diffusely distributed everywhere. And so, while there are some classic symptoms of small fiber neuropathy, and also the small fibers are part of the autonomic nervous system, so you can have lots of motility issues, for example. But we know that at least 40% of them have abnormal skin biopsies with the diagnosis of fibromyalgia. So lots of pain and fatigue syndromes associated with small fiber neuropathy for those reasons. So there is an association of hypermobility in MECFS, which is increased prevalence, frequency, and disability of migraine in females with joint hypermobility. There's an increased prevalence of migraines and other headaches in EDS patients with spinal manifestations. So this is really important because I think a lot of under-recognized reasons for headaches in MECFS are due to the ligamentous laxity and due to the connective tissue dysfunction. We know that the connective tissue involvement in patients with hypermobility contribute to a lot of headaches, which have etiologies that are often beyond the scope of most headache specialists and most neurologists. And I think that's a real important topic, especially for this group. So diagnoses like cranial cervical instability, atlantoaxial instability, tethered cord, and now we're learning more about these venous compression disorders also contributing, which change the intracranial pressures, are contributing to headaches. And so that is, an important, I think the hypermobility aspect of the headache etiology needs to be a little bit more of a focus in the dialogue that's going on, but also mast cell activation. I think people also underestimate the role that mast cells can have in headaches. A lot of talks is about sort of the inflammatory mediators, of which the mast cells release about 1,000 different mediators. The majority of them are inflammatory in nature. In terms of the histamine, which many people focus on, lots of people are on, and appropriately so, are on antihistamines. The brain and the cord have H3 receptors that are unique to the brain and the cord. So all of the antihistamines that you can buy in the drugstore are all H1, H2, but there are H3, and the brain has those too, but there are H3 receptors, and they're also H4, but they're not as well understood. But in the H3 receptors they help to modulate histamine. Histamine is actually a neurotransmitter, and it helps to modulate some of the inflammatory and electrical activity of the brain, and that's the H3 receptor's job. But when you are taking a lot of H1, H2 antagonists, then you have a whole lot of unopposed histamine, and the H3 receptors have great affinity for histamine. And so I think that it contributes to an extent to some of the, not only the headaches, but also some of the cognitive dysfunction, because it doesn't allow for proper modulation of the histamine in the central nervous system. And also there's other inflammatory mediators from the mast cells that also contribute. For example, there are some mediators that are proteases that break down myelin, which is the white matter of the brain. And the metabolites of the myelin breakdown actually are also then provoke mast cells. So it's this perpetual response of these mast cells that I don't think is well understood. And I think often not discussed enough, because it's just not about histamine release, block the histamine, and that now we've managed the mast cells. There's a lot more that goes into it. And it also degrades the connective tissue as well. So a lot of these proteases are, they're enzymes that come from mast cells that break down different kinds of tissues. So not only the myelin, the white matter of the brain, but also connective tissue, right? And there are a lot of different collagen types, and there are different proteases that have different targets. And again, it becomes very complex, but regardless, there's still further degradation of the connective tissue, which is not only made up of the fiber forming collagen, but there's also a lot of extracellular matrix that forms in the connective tissue. So those are all targets for some of these proteases that come from the mast cells. And then, of course, if there's any kind of inflammation from the inflammatory mediators, then all of that inflammatory response also further breaks down connective tissue, which is why when we have anatomical diagnoses of CCI, for example, we try our very best to manage those mast cells and manage the autoimmunity, because that is just creating further ligamentous laxity. That is creating further problems for the connective tissue, and therefore increasing the symptoms that you might have of CCI. And we do find that when you truly manage a lot of these inflammatory processes, those symptoms of CCI are better. The CCI is not cured, because that's an anatomical problem now, but they are definitely better and can certainly be managed in the interim, and if you're trying to avoid surgery. So headaches are a common presenting complaint. I mean, and maybe that's a skewed position in my part as a neurologist, but it certainly seems to be, when I ask the patients to list their most 3 to 5 prominent symptom, headache is always 98% of the time it's among them. And they range in severity, and they also range in distribution. I always ask about the headache. Migraine symptoms are common, but as I've already said, there are other types of headaches as well. They're usually chronic daily headache, which comes from the fact that many MECFS patients are on a lot of medications. I see a lot of polypharmacy, and polypharmacy contributes to chronic daily headache. We've known this for a long time in neurology. We talk about it all the time. And it's a very difficult headache to treat, frankly, because you have to wean patients off of some medications, and sometimes the weaning process can flare the headache. So I always tell patients when we're trying to manage a chronic daily headache, and I think it's, sometimes it's actually called overuse headache or rebound headache, that it often gets worse before it gets better. But it can also be hard to do that because, polypharmacy comes because patients have a lot of symptoms and you have to treat. And a lot of these medications have been helpful. So you have to sort of dissect what's what's useful and what's not as useful and try to manage the polypharmacy as best you can, because it does lead to chronic daily headache. But there's also other reasons. Autonomic dysfunction is definitely a major cause of headaches, whether it's because of hypovolemia, which is not the same as dehydration, but both can cause headaches, frankly, anyway. And then of course, hyperaginergic POTS definitely causes headaches. We know that MRIs with MECFS patients have a lot of T2 flare hyperintensities, which are these white matter foci, which, for a long time we thought it's just small vessel disease. It's, the brain is fed by large vessels, medium vessels, and then small vessels. And then there's these tiny vessels that feed the crevices of the brain, which the brain has a lot of crevices. If you've ever seen pictures of the brain, which I'm sure everyone has, it's got all these gyri and sulci. And so all these crevices have to be fed blood. And so that is done by these tiny, tiny vessels, of which just sort of are diffusely distributed throughout the brain. So when they are not receiving enough oxygen, they basically, and they're inflamed, they collapse under the weight of all that inflammation. And so then when they collapse, they basically no longer deliver the oxygen to that teeny piece of the brain that they were meant to deliver it to. And so you can see that on MRI, and that's what those foci represent. There was a recent study that showed that location of these foci do matter, because, classic neurology, conventional neurology and conventional neuroradiologists even just sort of like, just ignore those things. Though everyone has those. Certainly we've seen them in chronic migraineurs forever. And when we have a chronic migraine and we get an MRI and we see these T2 flare hyperintensities, we think, oh, because you have chronic migraines, which is not untrue, but what's the pathophysiology behind it is what we have to think about. And now we know that location of these foci really do matter. It seems that, for example, if they're in the frontal and temporal lobes, it's associated with hypertension and can definitely contribute to things like dizziness and cognitive dysfunction. We know that there's something called, we've always known that there's vascular dementia. So when it becomes really significant and a lot of the vessels are involved and it's diffusely distributed, it can definitely contribute to cognitive impairment due to vascular dysfunction. We know that if it's in the posterior fossa, so like the cerebellum, for example, then it can definitely contribute to certain kinds of headaches that are not migraines, but headaches that we very commonly see in MECFS patients. And that sort of brings me back to the whole hypermobility, with the hypermobility type EDS patients, we see a lot of connective tissue involvement, which then can lead to things like Chiari, or at the very least low-lying cerebellar tonsils, and CCI. So oftentimes a crowded posterior fossa, if not a true Chiari. And so then which can sometimes compromise blood flow, as does CCI, right? So CCI is an unstable joint and there's compression. In fact, we call it cervical medullary syndrome. And so there's compression of the lower end of the brainstem and compression of the vessels that feed the brain and drain the brain, and as well as compression of the vessels within that lower end of the brainstem. So that's just even more blood flow compromise, which again, just then leads to, if you are compressing the larger vessels, then the smaller vessels never receive their fair share of the blood supply. And so then as I said, they will then become inflamed and then just collapse under that weight. And then you can see those foci. So I think that's a really important piece that we need to do more research about, so that there can be more definitive understanding of how this is contributing. Finkelmeyer did an interesting study in 2017, which found that in MECFS patients, there were a lower volume of white matter and a higher volume of gray matter, which is why I'm a huge fan of a neuroquant, and I regularly do them on patients. So I often will order an MRI with neuroquant, which is a volumetric study. And I am finding what Finkelmeyer and his colleagues found, which about the white matter, gray matter volume ratios. And so that's really interesting. The gray matter is sort of like the cortex, and then the white matter, as I've said, what makes the white matter white is the myelin. And as I've already mentioned, the mast cells release certain proteases that really like myelin, that break down the myelin. Demyelinating diseases are one of these things in neurology, like MS, of course, is one of the more common ones. And we know it's an autoimmune disease. We don't know the antibody, but we know it's a demyelinating autoimmune disease. And so I think that there's a lot of, like points to connect here, that I'm often talking to other neurologists and I'm saying, don't you see it? There's something here that we need to figure out. There's a clear connection. Anyway, regardless, I'm sort of rambling because I just love this aspect of neurology where it's so it's so fascinating to me, and it's like a puzzle, right? It's a puzzle to piece together. And I feel like if we just can piece this puzzle together, then we'll have answers for patients. But without really understanding all this pathophysiology, it can be difficult to treat. So the etiologies, I mean, I feel like I've been saying all the etiologies as I've just been talking, but there's still a lot more, believe it or not. So the symptoms themselves of MECFS suggest neuroinflammation and abnormal brain function, right, play a role. And again, there's several theories. So connective tissue disorders, as I said, Chiari leak, dural leaks, right, are very common. The meninges are connective tissue. So which is why there's such a higher incidence of things like a dural leak, CSF leaks, spontaneous or otherwise. There are other reasons for leaks, Tarlov cysts, which again, another thing that we've just sort of waved off over the years in neurology. Oh, Tarlov cysts, they're incidental, they mean nothing, but they're collections of CSF fluid because of all the pressure, it pushes it out of the spinal canal. And these cysts sit on where the nerve root sheaths are. So it's these collection of just CSF that's sitting there. It was pushed into this cyst-like collection because of the pressure. And so it is a marker of something. And if it gets big enough, it can actually cause pain because it's sitting on the nerve root. It usually doesn't cause like dermatomal pain, which is what you would expect from a nerve root collection. But it over time they do cause, but it's also evidence of connective tissue dysfunction of the meninges, and not a frank leak because nothing is actually leaked out, but where it could potentially leak from the cyst itself over time and enough pressure. TMJ, so a lot of connective tissue disorder patients have TMJ dysfunction. So they have a lot of pain, and pain can radiate. And don't forget, everything in the head and neck is connected, right? All the cranial nerves, which all cranial nerves come out of the brainstem, and then they all become peripheral, right? So then they enter into sort of the face or the neck. And so there's a lot of connection between even atypical facial pain, TMJ pain, and headache. CCI, occult tethered cord. So connective tissue can definitely contribute to some reasons for headaches. CSF hypertension. So if there's elevated intracranial pressure, obviously IIH has been well known to be one of the reasons for headaches. Over time, we've sort of redefined it in many ways, because classically it was like it had, visual problems. And in fact, when I trained in neurology, we were taught that IIH, the biggest fear was you were going to lose vision permanently, because that is what can happen. But without papilledema, without optic nerve involvement, it wasn't that big of a deal. And you can do a lumbar puncture to assess opening pressure. And if it was elevated, then you could put them on acetazolamide. That was sort of how it was looked. And if there was no visual involvement, then there wasn't a big concern. But we now know that, especially in MECFS patients, visual involvement is not usually a presenting concern. In fact, pulsatile tinnitus is one of the more common things I hear with elevated intracranial pressure. And then headache, of course, and again, another big reason for headaches. So you can definitely do the carbonic anhydrase inhibitors like acetazolamide and topiramate for sure. But sometimes you have to actually do what's called a high volume tap and remove some of the CSF, so that you remove some of the pressure, and you'll get spontaneous improvement of the headaches. The problem, of course, with that is with the meninges being connective tissue, MECFS patients are at greater risk of prolonged leak after the lumbar puncture. So you have to sort of weigh the pros and the cons for sure. But you can also have intracranial hypotension that causes headaches. And hypotension and hypertension have their own classic set of symptoms. But again, nothing is classic and typical in the MECFS population. And in fact, if you have CCI, you can sometimes have elevated pressure in the cranium and low pressure in the spinal canal, vice versa, or low pressure throughout, high pressure throughout, because of the compression of the CSF flow from the cranium. I'm going like this, like I'm kind of myself, because of compression of flow from the CCI, from the unstable joint, which can compress some of the CFS compartments. And there's also, don't forget, there's exchange of all of the fluid compartments of the central nervous system. So you can, so where there's elevated volume in the CSF compartments, it does affect the compartment, the arterial and the venous compartments as well, because they all have exchange between them, which affects actually the glymphatic system. So the glymphatic system is how the brain rids itself of its metabolic waste byproducts and all of its cellular debris from all of the many, physiologic processes that go on in the brain. It's most effective when we sleep. And as I've already mentioned, there are documented circadian rhythm disorders in MECFS. So sleep is usually not restorative. And it's only during restorative sleep that the glymphatic system is really that functional. So in essence, the brain is not ridding itself of its waste, because it's the lymphatic system of the brain. And so therefore what's remaining and what's residual are these foci that are just inflammatory for the brain. So there's greater level of neuroinflammation in MECFS. So again, the most common symptom of neuroinflammation is headache, but clearly that also weighs into cognitive dysfunction and cognitive fatigue, some of the other kinds of neurologic manifestations that a lot of patients with MECFS have. I've already mentioned the venous compression disorders. In fact, we now know that any kind of outflow disorder contributes to what we still call IIH, or sometimes called pseudotumor, only because it was called pseudotumor early on because it's the symptoms of IIH mimicked the symptoms of an intracranial tumor. So it was called pseudotumor cerebri, which I actually think is a better term right now than IIH because it's not idiopathic, in my opinion. But regardless, we now know that venous outflow or venous congestion disorders contributes to elevated intracranial pressure and contributes to headaches. We just had this phenomenal case, Dr. Bolognese and I at the Mount Sinai EDS Center. He had this case that this woman had a headache for years that just kept getting worse and worse and worse. And all this workup by neurologists couldn't find reasons for it. She was given lots of medications. He did a bilateral stylolectomy. Her headaches improved. He was doing manometry. The opening pressure went down, but it still wasn't normal, and she still had a headache. He did a lateral resection of the C1 tubercle, which is sometimes the reason for the compression for the jugular venous outflow, and her pressure went down to normal, and her headache was completely gone. It was the first time she hadn't had a headache in 7 years, and it was pretty impressive. So it goes to show you how important looking at outflow and congestion disorders can be for this population. And I will say there's actually a group, we haven't come up with a name yet. We're sort of trying to decide on a name. It's neurologists, it's neurointerventionalists, it's neurosurgeons that are really focused in on this and really looking to do some studies to sort of see how we can better improve the knowledge on this, and so we can better help patients. But it's becoming an important etiology of headaches for sure in MECFS patients, especially those with connective tissue disorders, which I would say the majority of them have a connective tissue problem. Yeah, it's definitely, I know it's that, I think that it's, one of these things that people aren't really saying yet, but hypermobility in MECFS is more commonly found than it is not found. Anyway, other reasons for headaches, the vasculitides, which is like vasculopathies. So again, the inflammation that can come from mast cells or from autoimmunity, vasculitis is a very common coexisting diagnosis with autoimmune disorders in general, like lupus even, or Sjogren's. They all have vasculitides. And that would include all vessels, including those of the brain. So the vasculitides can cause definitely headaches. Any kind of ischemic blood flow abnormalities, which I've already sort of mentioned, but certainly any kind of stenosis or compression. We do know that MECFS patients have lower cerebral blood flow velocity. We do transcranial Dopplers at the Chiari EDS Center at Mount Sinai, and 90% of them have been found to have low velocity of cerebral blood flow. We don't know all the reasons for it, that we don't always find compression. I don't want to make it sound like we always find compression and stenosis. We don't always find that as the reason, but we think that the viscosity of the blood is such because of all the different inflammatory mediators and all the different autoimmunity, and even autonomic dysfunction, which includes, when you have autonomic dysfunction, it modulates the caliber of the vessels. So the vessels are supposed to dilate or constrict based on your position, so it can contain the volume and pressure appropriately. It's one of our homeostatic mechanisms, right, to keep it to keep it maintained in a stable fashion, so that things are getting appropriate blood flow no matter what you're doing, no matter what position you're in, no matter what you're trying to accomplish, right? The vessels are there, they have receptors, these baroreceptors and chemoreceptors that are all part of the autonomic nervous system and help, again, to maintain volume and pressure. But when you have dysfunction, they don't do that nearly as well. So sometimes the blood flow abnormalities are related to autonomic dysfunction of the vasomotor component. Mitochondrial dysfunction, we know that the bioenergetic compromise that we see with MECFS, which we think underlies a lot of the post-exertional malaise and the post-exertional fatigue, the mitochondria just become overwhelmed because of all of this systemic and neuroinflammatory response. The mitochondria can only do so much. And I often do mitochondrial testing in patients, and we find, it's usually not a mitochondrial disease. I mean, I've done a lot of mitochondrial genetic testing, and I have very rarely found any kind of genetic component behind it. But what I do find is that there's poor functionality of the mitochondria, of the electron transport chain. I don't know how much everyone knows about mitochondria, but the energy powerhouses of our cell, every cell contains them, and depending upon how metabolically active an organ is will dictate how many mitochondria per cell there are. And of course, the brain, very metabolically active, so thousands of mitochondria. And so they're comprised of basically a chain of enzyme complexes, and we call it the electron transport chain. And it's like any other chain, right? If there's a weak link, the chain isn't as optimal in its functioning. And so there are ways of testing for the functionality of each of those enzyme complexes to see if they are online and functioning normally. But we do know that with MECFS, they are overburdened, and we refer to it as we think it's about the cell danger response. And Dr. Bob Naviaux coined that term, and he's written a couple of really amazing papers about it. And he and I have had lots of discussions regarding it. And what happens is we think in MECFS, these cells get stuck in the cell danger response. So it's like a 3-phase cycle that we all go through, everyone, it goes through the cell danger response, and the cells come out of that cycle, and the danger is gone, and they can relax, and the mitochondria can go back to working and functioning normally. But with MECFS, it seems like they never get the message that the danger is gone. It's like danger, danger, danger. And when they go into the cell danger response, they sever their connections with their neighboring cells, and they just sort of hunker down and protect themselves. And so when you don't talk to your neighboring cells, every organ has less than what we call the critical biomass, which is what every organ needs to function appropriately, including the brain. But when the cells aren't talking to their neighbors, then that biomass isn't sensed, and so that the organ itself is not functioning as optimally. So there's mitochondrial dysfunction that we also try to work on, and it's part of my treatment plan with MECFS patients, and it definitely seems to improve their headaches as well. Central desensitization, which I've sort of already mentioned with regards to just overall increased sensation of pain that may be disproportionate and definitely overwhelming, and for sure life impacting. And then, as I've already mentioned, the H3 receptors and H4 receptors are unique receptors for histamine, and there's a lot of mast cell activity that's going on. And don't forget that there's mast cells are everywhere. They're ubiquitous in our bodies, but there are different types of mast cells that reside in different parts of our anatomy, and there are connective tissue mast cells. And the connective tissue, usually the connective tissue is nice and tight and taut. And so the mast cells just sort of sit there waiting for them to be told that, they need to come and help. They're part of our innate immune system. And so, which means that they're our first responders. So we're assaulted by something, whether it's a virus, a bacterium, mold, some other toxicant or contaminant, of which there are many. That's one thing that my PhD taught me. Our environment is dirty, and it's just getting dirtier. But until that time, they just sort of sit and reside and hang out in the connective tissue. But the problem with connective tissue dysfunction is that there is holes in the connective tissue, right? It's not as tight. So those mast cells are not as protected. So they tend to see things that are just sort of floating around in the blood, and then they see danger, danger, danger. They just sort of see, too much danger, and they feel like they have to degranulate to come and help the body, to help the immune system. So they degranulate, but they are never told that danger is gone. They're never told that the danger has been fixed, that everything is okay, that everyone is safe, and that they could just calm down and go back to their little nest. and they just continuously degranulate. And as I've already mentioned, some of those mediators actually are autocrine in fashion. So then just sort of provoke the mast cells even more. Some of them are, proteases and break down the connective tissue even further. So it's just this perpetual cycle that ends up with lots of pathology and just unfortunately lots of symptoms that the patients suffer from. And so the goal, of course, is to manage all of that. And that can be hard, which brings me to treatments. So it really depends on etiology. As I hope I've made clear, or maybe not, because I feel like this was a mouthful thus far. And treatment alone is like a whole other talk, but it really depends upon what the most prominent etiology, I should say, is, because I would argue that probably most of what I've talked about plays a role, some sort of role, in all MECFS patients, right? So we do know that this new class of medications that have been made for the migraine population, CGRP antagonists, are actually surprisingly helpful for a lot of sort of the pain syndromes of patients. CGRP is just a pain molecule, and I think that's why it doesn't go to the root cause of it, of course, but it does at least relieve some of the pain, which, it initially is really all the patients want. When you're in pain, it affects you in so many different ways. It affects your focus, your concentration, your mood, your ability to even be motivated to do anything, good for yourself. I often talk about, even lifestyle options to just promote, less inflammation, but who wants to eat a salad when you're just in pain, really? Like, you're not motivated to eat well, you're not motivated to do much of anything. So it just sort of helps to modulate the pain. And so the CGRP antagonists have been very helpful. Diamox and topiramate, as I mentioned, those are the medications for elevated intracranial pressure. They're both they are both carbonic anhydrase inhibitors. Carbonic anhydrase is the enzyme that helps make the cerebral spinal fluid. So it helps to reduce the volume of cerebral spinal fluid, which is great if there's too much of it. Diamox, of course, is very powerful and potent. Topiramate has weaker activity of carbonic anhydrase inhibition, but regardless, it's still helpful. Sometimes I add a little bit of furosemide, which is Lasix, which is just a diuretic, but just as I've already mentioned, there's exchange between the fluid compartments of the brain. So the more I can even remove from the systemic circulation sometimes will aid either I usually add it to topiramate because it's just weaker in its carbonic anhydrase inhibitor. I don't really add it to the Diamox. Regardless, some patients don't tolerate some of the side effects of Diamox, which is like paresthesias of the hands and which is transient, but it can be really annoying to patients. And then sometimes their potassium levels are hard to manage on Diamox. I often have to put them on potassium supplements, then I have to manage the potassium. And then sometimes it just doesn't work, and even at high dosages. So, and that's when I have to look at some of the anatomical problems. It's important to note, I always say that if the best of our medications don't work, you have all these treatment plans, all these treatment regimens, and look at the anatomy, because the anatomy is the problem. Tricyclic antidepressants, of course, are popular headaches like nortriptyline and amitriptyline. They also help sleep, and at higher dosages, they can help mood for sure. But I don't find them to be as effective for the headaches. If there are true migraines, they can be very effective for sure. We still use Botox, which are effective for, as you know, also approved for migraines, but I use them for non-migraine headaches, but that have a similar distribution. I will give Botox injections. With EDS patients, I avoid the neck areas and often the occiput regions, and even sometimes the trap regions I'll avoid. We'll do occipital nerve blocks, which is not Botox, of course. Botox, paralyzes the muscles, and that's the last thing you really want to do if you've got a true CCI patient. But occipital nerve blocks can be very helpful. Trigger point injections, stellate ganglion blocks, these are all can be very helpful. And again, they just block pain perception. So I will definitely do those. They're temporary though, but at least will give some relief. Steroids are, if you can tolerate them, can be very helpful. They're not a sustainable answer. You can't be on steroids forever, because then they have other problems. They not only elevate your blood and elevate your blood pressure, elevate your blood glucose, can impair sleep further, which, there's already impairment of sleep in MECFS, but they can cause osteoporosis, and, bone tissue is made up of connective tissue, which is another reason why there's so much osteopenia, if not osteoporosis, in young patients with MECFS. So and it's very hard to get them approved for the medications for osteoporosis because most of those medications were FDA approved for, postmenopausal women. So it's hard to get, I have, patients in their 20s and 30s that have osteoporosis that have, EDS. And so anyway, so steroids can worsen that. IVIG is really effective for many. Again, I think it's because of the autoimmunity that we know is involved. It's not uncommon not to know the antibody. And just because we don't know the antibody doesn't make it untrue. In fact, I could tell you a bunch of neurological diseases that are well accepted and well known and well understood that we don't know the antibody. But yet, I already mentioned MS as being one of them, but there are several others. And in fact, take a diagnosis of myasthenia gravis, for example, which we do know the antibody, and we've been testing for them for years. But when I first started neurology, we were testing one or maybe two. Now there are like 6 or 7. So the point is that we're always learning about antibodies. So just because we don't know the autoantibody does not make it an unreal disease or a controversial disease. If there's a CSF leak, of course, blood patches can be helpful. They can be temporary, though, often if there's chronic CSF leaks that are causing the headaches. And I've had patients who've had 3, 4, 5 blood patches that they get temporary relief, which is why they keep going back, but it's not sustained relief. Mast cell activation management. So as I said, a lot of the antihistamines are appropriate, but I'm really about stabilizing the mast cells, and a lot of medications that do that. Of course, the things like cromolyn and ketotifen and LDN are great mast cell stabilizers. Aspirin's a mast cell stabilizer. Benzodiazepines are great mast cell stabilizers, but obviously you don't want to go crazy with those. And then, of course, there's the surgeries. Meaning that, the fusions and the section of the filum terminale for the tethered cords, the styloidectomies for the Eagle syndrome, the C1 tubercle resections, stenting, there's a lot of different surgeries that can be done for the anatomical diagnoses that contribute to headaches. And then, of course, there's lots of pain meds. I didn't add that to this list because, I've gone down the list of different pain meds for headaches to treat them. But again, it really does depend upon the etiology. And that's my talk. These are my social media things. And then I have this podcast with David Kaufman. We're going to be discussing headaches in the next couple of episodes that we're going to record. And so I would love for you guys to subscribe to our podcast. We have a lot of fun on it. And it's just me and him just chatting, really. We talk about how it came about, which is that we used, during the pandemic, we just would get together for coffee like every 2 weeks. And we would just sit and chat. Like, we always say we were 2 Jews from New York, two Jewish physicians from New York, and we would just sit and just chat. And the conversations went for hours, and we would ramble off on different topics. And it was always about medicine, always about patients, always about MECFS, and always about the different symptoms. And we thought people should like eavesdrop and listen in. And then we came up with this idea about doing a podcast. And so we just sit there and we just chat. And it's really interesting. And I think it's fun. So, consider subscribing. Anyway, so that is my talk. So I went a lot longer than I thought I would. So I apologize. I know I talk fast. I'm a New Yorker. It's what I do, but I'm happy to answer any questions. And yeah.
Thank you so much for that, Dr. Ruhoy. Some questions popped up while you were talking. I'm going to see if I can ask some of those first. Let's see. Sure. I think you addressed this when you were talking about IIH. There was a question about what about the link with tinnitus, and I think you mentioned pulsatile tinnitus was associated with that. Do you regularly see visual disturbance with headaches too, with visual hallucinations?
So again, there's things called migraine accompaniments, and I very often will call a lot of symptoms that MECFS patients have migraine accompaniments. Migraine accompaniments are symptoms that can accompany a migraine, but you don't have to have the migraine, meaning you don't have to have the head pain that usually follows the symptoms. And visual obscurations are definitely one of them. Now, if it's followed by a headache, then that's a classic migraine, because then you've had a visual aura and then the headache, which is how a classic migraine is defined. But if you don't have the headache, some people just call them ocular migraines, which I don't think is an accurate term, because the retina has a lot of electrical activity for sure, and that's why if you sometimes when you close your eyes you could see things. And that's just the retina with its electrical activity. And that's just a well-known phenomenon and not dangerous at all. But if you have visual hallucinations or any kind of visual obscurity, and that could be, again, it could be a scotoma, which is sort of the central area of blurriness or loss of vision. It could be true loss of vision. It could be graying of vision, or like a curtain comes down where it's not clear and you don't get a headache. It could be a migraine accompaniment, but it can also be related to intracranial pressure for sure. But what we worry with IIH and vision is that if you're starting to lose the vision, so it's a very hard thing to dissect because a lot of patients will have visual concerns. It's a visual acuity concern more than anything else, not visual phenomenon. And so visual phenomenon is usually a migraine accompaniment and not usually related to elevated pressure. If you're losing vision, so if the acuity of your vision is going, then and you have optic nerve involvement, that's the key, right? So you can have all kinds of visual complaints, but if your optic nerve looks fine, then it's not related to the intracranial pressure. So that's the way we diagnose it. So I always do when I can, a funduscopy. I do a lot of telehealth right now. So unfortunately, a lot of things that I find very useful on an exam, I don't have the option to do for my patients. But a funduscopic exam, you can absolutely see the optic nerve. But what's even better is to be dilated by an ophthalmologist and get a true view of your optic nerve. If there's optic nerve involvement because there's too much pressure, then that's a big concern, and that needs to be treated, I would say, fairly urgently, because then you do have a risk of losing your vision, which has, as I said, has been the classic fear of IIH for a very long time in neurology. But if your optic nerve looks fine, which I have to say in the majority of MECFS patients with any kind of vision concern and a concern for elevated intracranial pressure, their optic nerve does look fine. So, but they often have pulsatile tinnitus, which is another way that this can present, which has been not well understood for a long time. And in fact, pulsatile tinnitus, the classic teaching in neurology is if there's a concern of pulsatile tinnitus, you look for a fistula, right, where the artery and the vein are communicating where they shouldn't be, right? So then you hear the whooshing of the blood, whoosh, whoosh, whoosh. And so if a patient says I have pulsatile tinnitus or tinnitus, however you want to pronounce it, then you want to do vessel imaging to look for a fistula. That was the classic training, but I don't often find, in fact, I've rarely found a fistula. I think I found it 5 times out of like hundreds of patients. But what I did find was elevated pressure. And what I did find was outflow disorder. So some sort of congestion, whether it's, again, don't forget the vessel walls are also made up of connective tissue, right? So they often can collapse upon themselves, not just the small ones as I discussed, but even the medium and moderate sized ones, and even the large ones, the jugulars, for example. When we're supine, the jugulars open. When we stand up, they close. That's what they're supposed to do. So, but they are made of connective tissue, and so they can fall in on themselves, and so it can actually impair blood flow. It doesn't have to be true stenosis. That's the other thing about radiology, right? So I need to find, there are a bunch now, and they're trying to train other radiologists, but we need like an EDS literate radiologist reading these things, because they might say like, some narrowing, but not, stenosed. That might be their terminology, but that's important on an EDS patient. Narrowing is not good, right? But unless it's truly stenosed, they don't make anything of it. They just say some narrowing, but otherwise blood looks good, flow looks good. So you need manometry, which does measures gradients of flow. I think I'm way off this question now, but there's so much to say and there's so much to talk about. But so radiology has always been an obstacle as well. So I guess the question, pulsatile tinnitus. So yes, it can come from any kind of outflow disorder for sure. Again, it could be stenosis, it could be narrowing, it could be compression from the styloids, compression from the C1 tubercle, and then it just requires a decompression procedure. And I will say that in the meeting that this new group that doesn't have a name yet, we just had in Hawaii in January, we talked about how when you resect the tubercle, the pulsatile tinnitus, it spontaneously resolves. I mean, it's pretty impressive what can happen for patients. I wish it was for everyone. It's not, of course, because this is multifactorial, but these things need to be looked at, and that's what pulsatile tinnitus is. So yes, it can definitely be a presenting symptom of elevated intracranial pressure, and then you need to go look for the reasons why.
Here's another question. Let's see. How do you balance using Diamox and topimer? I can't say that. I just call it
Topamax, yeah.
I call it Dopamax because I
Yeah.
felt like I was doped up when I was on it.
Yeah.
How do you balance the use of Diamox and topimerate in patients with orthostatic intolerance and POTS?
That's a really good question. Very carefully, very carefully. So the Topamax is, it's not a diuretic per se, right? So it's I mean, I know it's classified as a diuretic, but it's only because it reduces the amount of CSF. So, and then otherwise it relieves pain. So it doesn't seem to actually flare POTS symptoms anyway. So if a patient has elevated pressure and POTS, then I will try topiramate first and foremost. Diamox, because it's so powerful of a carbonic anhydrase inhibitor, it can have some otherwise systemic diuretic activity. So that could be a little bit, I have to do that a little bit more carefully. And I just manage it by, I really, to be fair, I do it clinically, like how their symptoms are. Obviously, they're already on some sort of POTS management for the most part, because that is the first place that most of us usually start, is managing POTS in the mast cells. And so, and then depending upon how severe their POTS is, and I do autonomic testing. So I'm of the opinion that POTS is like a surface diagnosis, and there's usually some more autonomic dysfunction that maybe hasn't even evolved yet, but will evolve. And so I know how to, I very closely monitor a lot of the autonomic function, which, as I said, is not just about heart rate and blood pressure, but I monitor even things like motility, how many times you poop in a day kind of thing. And, how severe your symptoms in terms of change of position, when you walk, your activity levels, when you go up an incline, so things like that. So I'll manage clinically how their POTS and dysautonomia symptoms are doing while I'm managing their elevated intracranial pressure. And then I know how to tweak medications. And it's not an exact science, to be completely honest. I mean, it's more art over medicine, frankly. And if there's these anatomical diagnoses, it really limits what we can do pharmacologically. I will admit that. So, I think a lot of doctors don't want to go towards the anatomy because it becomes such an obstacle, because then you have to find, as I've already mentioned, the radiologists and the surgeons, and, it often requires hospitals to accept, these patients, which, if you don't have these, literate, neurosurgeons and neurointerventionalists, on staff at these hospitals, you have a hard time getting the patient admitted. One of the problems that I've had, of course, is being in private practice, is that I'm not associated with any hospital here in Seattle, so I don't have much luck. That's why I'm trying to educate others. But at Mount Sinai, obviously it's a different story. So any kind of New York-based patients, it's a little bit easier. So I manage a clinic, but if there's an anatomical reason behind the POTS and the pressure, then I just manage it really. I have to manage it as best as I can while I get them to the proper surgical intervention.
Thank you.
You're welcome.
Let's see. Just a FYI for you, when we first formed this group, a lot of the original members of physical and occupational therapists have ME, or they have a family member that has ME. So here's a question from an OT who has ME. She said, I requested to see an immunologist, but the tryptase test showed nothing, but I'm guessing that's not a useful test.
It's not useful at all. I mean, you can have hereditary alpha tryptosemia, which is what the levels of tryptase can tell you, but it is not even close to a marker of mast cell activation syndrome. But by the way, that experience is not unusual. And in fact, in my hospitals out here in Seattle, they have this thing where if your tryptase is normal, they will not acknowledge mast cell activation syndrome, and they will not treat you for it. And so, no, that is not appropriate at all. And I mean, again, it's appropriate for HAT, hereditary alpha tryptosemia, but that too is treated basically like mast cell activation syndrome. So there's a whole mast cell workup that we do that actually I learned from Dr. Larry Afrin, the mast cell guru himself. I'm part of a listserv group of now, I think we're up to 300 doctors on the listserv. And maybe even some of the members of this group, it's not only doctors, but maybe even some of the members of this group are on it, because I know that there's therapists on it, physical therapists and occupational therapists as well. But there's a whole lot of learning going on in that group, whole lot of learning. I'm not as active, in the past year as I'd like to be on it, only because I just don't have the time, but it's very active and there's a lot of things to learn. My point is that we all talk about all the different labs that we do to help understand how active those mast cells are, like how they could be contributing to the symptoms. And there's a lot of different things to look at. As I've already mentioned, it's not just about histamine or tryptase. It's about 1,000 different mediators, and you can't test for all of them. So to be fair, it's not like we're testing for 1,000 mediators. You can't test for all of them, but you can test for quite a few, and you can test for the effects of some of the others. So it's a whole panel that we do. And if any one of you have had workup for mast cell activation, you know that 30 vials of blood are often taken. And I often warn patients when I send them for labs, like, eat well, be hydrated. So yeah, so again, that's not appropriate, but not an uncommon experience.
Let's see. Thank you for that.
I have a question. How much attention is the lymphatics system getting in your network of doctors? Is there some research going on that is really looking at that system?
It's not getting as much attention as it should. I have a lot of focus in on it because I truly believe that is behind a lot of the symptoms of the MECFS patients. There is some research going on in lymphatics. Yes, there definitely is, but unfortunately not in the MECFS community. It's amongst neurologists that are interested in the lymphatics, but they're not MECFS neurologists. But I am hoping that the two shall meet, right, at some point. You're muted.
The glia cells.
The glia cells. Oh, okay.
Yeah.
Oh, sorry. I thought you said the lymphatic system. Yeah, no, there's a lot of research on the glial cells. So yes, for sure, the glial cells, which are the immune cell, one of the set of immune cells of this, the brain actually has its own immune system. And part of it is the glial cells, of course, but there's meningeal lymphatics. Even cells from the bone marrow of the skull are actually recruited. So like mast cells, for example, even they're recruited when there's any kind of inflammatory assault on the brain and the cord. So we always talk about how there's privileged, the central nervous system tissue is privileged. I think it's better to say it's specialized because it's got its own active immune system that includes the glial cells and some of the other immune cells and the meningeal lymphatics and the bone marrow of the skull, which then will be incited to release a lot more immune cells and a lot more precursors of immune cells and a lot more precursors of certain chemokines and cytokines that are anti-inflammatory and part of the immune system. So there's a lot of research going on in that area, a lot of really good research.
And back to your comment about the lymphatics, there's a lot of, we have a lot of therapists here, including me, that have trained with Dr. Perrin, which, we do see some improvement in some MECFS patients with the Perrin technique.
Yep, absolutely.
And lymphatics. What is your experience with low-dose naltrexone as a treatment for daily headaches related to ME?
I like low-dose naltrexone a lot. I see it not as helpful for headaches, but very helpful for neuropathy. Not that some people haven't gotten improvement with their headaches. Some people certainly have. I haven't seen a robust response with regard to the headaches with low-dose naltrexone, but it definitely helps neuropathy.
I have a question. The CGRP meds have been a life changer for me between the Aimovig monthly injection and then the Ubrelvy.
Yep.
I recently stumbled across a talk where they were saying that CGRP meds have been linked to osteoporosis. Are you familiar with that at all? Is that something that you've heard?
Yeah. Long-term use is sort of thought to contribute to low bone density, but the research is not yet, it's not a conclusive I don't believe it's conclusive yet. I think that they have to do a more widespread study to sort of really know its effect on the bone, because the patient population that they studied it on, they didn't really get appropriate bone workup prior to doing the study. So but a lot of these, so again, a lot of these medications do have effects on bone, because bone is bone is metabolically active and it's got connective tissue. So it's very vulnerable to a lot of different medications. Specifically, the MS drugs are really known to be very harsh on the bone as well. So I have read that, but I'm not so sure that it's a conclusion that I'm yet comfortable avoiding the CGRP class for, because it's been so helpful for my patients. You're muted. I think you're muted.
And when I unmute, the question dropped down. Okay. With a general overview of your ME patient population, do you see a reduction of overall headache pain level in any way with the successful management of post-exertional malaise through pacing? Or is that too broad of a question to answer?
I think it's too broad in some respects, but I think for some people, I think when they pace themselves, they don't experience as much of a flare and as much of, which would include headaches. As flares are, we define flares of symptom flare, right? So, and very often part of that is headache. And so when they pace themselves, they don't have flares, so they don't have as many headaches, but it doesn't mean I think that their headaches are improved, right? We have to sort of get to the root cause of MECFS and why they have such a need to pace themselves. There's lots of different theories about post-exertional malaise and fatigue, none of which we've proven yet, but there's a lot of different theories, and some are peripheral in nature in terms of, whether it's like a primary muscle problem, primary mitochondrial problem, or some are central in nature. So is it a primary, brain issue? Some people think it's a mast cell issue. I don't think it's that though. But so anyway, yeah, so people shouldn't have to pace themselves, right? It shouldn't be the problem.
So in the pediatric community, kind of word in the support networks is a lot of times that pediatric ME early on has symptoms that have more abdominal manifestations, and not necessarily as much for adults, but kids often complain more of the abdominal pain.
Mm-hmm.
And then over time transferring to pain, more headache in nature, that they kind of switch and swap. Is that something that you can confirm, relate?
Oh,
have
100%.
anecdotes?
100%. So migraines are well known to be abdominal in children before they become of the head. Cyclical vomiting syndrome is actually considered a migraine accompaniment, as I discussed. So it does seem that, and as we know, the gut brain has lots of connections, right? The enteric nervous system and the central nervous system, they love each other. There's lots of interconnections within them. And we think that early on, with kids, that those connections are that much more close. And there isn't a whole lot of buffer in between as there are as we grow and as we become adults. There's a lot more buffer in it where you can have like days of just, horrible gut stuff going on, but not necessarily have central nervous system manifestations, because there's a lot more buffer in between. Kids don't have any buffer. So it all starts in the belly, and often the head won't even get the sense of it because it's all being contained and concentrated in the belly. And in fact, there's this new treatment called IBS stim that is really effective for any kind of abdominal migraine, any kind of abdominal ME symptom. That is, I know actually, in fact, I don't know if anyone was listening when I was talking to Melinda when I first got on, but Jillian Ehrlich's practice, she does the IBS stim, and it's been a game changer for some of, especially the teenagers that come in, have all this abdominal, and of course they've all had gastrointestinal workup, which I always insist on. One of the challenges of being a doctor for the MECFS population is that you don't want to miss something otherwise. It's just because, it's not in your specialty, so you're not thinking about it. And I think that is a challenge in the sense of like, which is why I think more MDs, DOs need to be part of the MECFS community, because we've all been trained in everything. And we've all been trained to know what our limitations are and what we know and what we don't know. So, and we've all been trained, our residencies train us like, we know when something's going wrong fast, right? Whether it's in our specialty or not, we're left to take care of entire hospitals, overnight, where the buck stops with us, right? That's what residency is about. So you get this almost like sixth sense, or like I always call it gut instinct of when like this doesn't sound right, like something's up. So, when patients come with, primary abdominal complaints, I always make sure they've had a full GI workup. When they come with like chest pain or their heart's always like, their rhythm is off, I always make sure they have a full cardiac workup. If they come with syncope, actually, syncope is one of those things that is shared by both cardiology and neurology, right? I always make sure they have a good cardiac workup. I don't want to miss something otherwise, just because I'm a neurologist, and I don't want to just assume this is MECFS. So my point is that, with all these teenagers that come in, or even younger than teenagers sometimes, I've got 8 and 9-year-olds that are clearly hypermobile, beyond what an 8-year-old normally is, I should say. And then, and they have all these other symptoms, and I'm like, oh, this is a pentad forming. I refer them for the IBS stim, and it really does help. And I do believe that the earlier you treat, the better off these kids are going to be, and they won't evolve into having this adult kind of MECFS, which obviously can be very debilitating. I mean, I have many of a housebound, if not bedbound patient. And so my goal is to be as preventative as possible. In fact, if you take the diagnosis of PANDAS and PANS, I'm sure most of you are familiar with those diagnoses, they're still controversial, but less so than they used to be. I mean, I used to work at a children's hospital that would basically triage these diagnoses out. They couldn't be seen by neurology. They couldn't get into neurology because they weren't considered. And I now see a lot of adult PANDAS kind of patients. And I realize when I take a history, which of course is the most important thing when you see patients, you take a history, and you learn that they were having these symptoms since the age of whatever, early, young, 5 years old, sometimes early as 5. And so the goal, of course, is to treat as early as possible so they don't evolve into having symptoms while an adult, because then their life is, of poor quality and not functional and not productive and not happy, frankly. And my goal is to have happy patients. So yes, it's all centered in the gut in kids, not always, but often. And treating it from the gut is key. Don't ever let the head get a wind of it. Keep it in the gut, treat it in the gut, cure the gut, and let them be happy.
Because I know that there's a lot of reasons why there's gut pain, but it seems like they're, especially when it's like a new part of the illness and it's just emerging, that there's so much lymphatic involvement. So there are the lymph nodes under the armpit and the neck, but also all of the lymph nodes around the stomach.
Absolutely.
Are involved.
Absolutely.
So it just seems like that piece of it is so unique to kids that, like you were saying, like it presents differently with adults, but it just makes it so important that pediatricians are knowing that, it's not just anxiety and nerves, and it's not anything like that. It truly is like those lymphatic system is on hyperarousal. It's something's going on for young.
I 100% agree with you, Amy, for sure. I mean, there's no question, because so kids get these recurrent infections and everyone thinks, oh, kids get sick, right? But the lymphatic system is involved whenever there's an infection. And kids' lymphatic systems, I call them primitive. I just don't know a better word. They're just not fully developed yet. Like our brain develops until we're 23, 24. I tell my 19-year-old, like, your brain isn't fully developed yet. You can't make your own decisions. But, they're in a state of development all of the time, kids. Their lymphatic system it lags behind the rest of the development of their body. So if they have recurrent infections and they're given all these antibiotics, their lymphatic system is burdened. Talk about mitochondrial burden, lymphatic burden, right? And all those lymph nodes within the gut for sure are taking on the burden, which is why we think it's all centered there, but it's so under-recognized amongst the pediatric world. And again, the more we talk about it and the more we research it and the more we write about it, then I think that these kids will be better off, and they too will have better childhoods, right? Because we can get their symptoms under control a lot faster.
Yeah, my mind goes back to one patient in a very, very well-known OTPT clinic, rehab center, that the goal was, I mean, it could clearly see that this child had early onset of ME. And the goal for this child for OT and PT was to get out of a fetal position, to be upright and start walking again. And it was so hard to watch this happen, thinking like, well, it's not this person's
right.
choice to be in a fetal position. Like what, that cannot be an OT-PT goal, you know, like
That's exactly right. That's exactly right. I mean,
those are
everyone
not
referred
goals.
to OT-PT. I know, I saw it in the children's hospital. OT-PT was the constant place that these kids were referred to without even a diagnosis. It was really interesting to me, without even understanding what was going on physiologically and without even starting any kind of treatment, other than sometimes they would just give some like gabapentin, you know, for the pain and then send them to OT-PT.
Yeah, like stretching them out will make it better. I mean,
Right.
it just
No,
doesn't make-
exactly. I completely agree. I think for my adult patients, I mean, I always refer to OT-PT, but you know, EDS literate ones, of course, because, you know, these patients are on a treatment plan. And I always tell all of my EDS patients, a cornerstone of your treatment for the rest of your lives, unfortunately, but you could take breaks, but for the rest of your lives, it's going to be OT-PT, because it's going to keeps your body functional. You know, I always talk about how important the anatomy is, and you know, we don't really give the anatomy a lot of credit, but where all of your organs, joints, spindles, where everything sits is genetically determined. And it's because that's how the body signals to each other, right? That's how everything happens. Like, you know, every cell talks to another cell based on where that cell is supposed to be. And I always talk about that with patients. You know, it's not just like, oh, you're out of alignment, you know, you needed an adjustment or you need a massage or something. You need true professional OT-PT to sort of put things back in the place that they are supposed to be so that they could speak to one another again and you can have more optimal functioning. It is so important. It is so important. I mean, no one talks about cellular signaling and how important that is. I mean, there are entire disease classes that are all because a cell didn't get to where it was supposed to be. They're called migration abnormalities and migration disorders in neurology. Where a perfect example is like heterotropia, right? Where a cell that's meant to be the cortex, which is the gray matter, stops in the white matter, never gets there because it loses its signal and just stops there during development. And then when you get MRIs in these kids, you see cortical cells in the white matter, which shouldn't be there, right? And they have seizures and some cognitive issues. And there's a lot of different disorders and depends upon how bad it is and so on. But it's a perfect example of when the cell loses its signal and just doesn't know where to go, it doesn't know what to do and just stops where it shouldn't be. And so the signaling is all off, right? So it's the same. And obviously that is a severe side of the spectrum, of course, right? But when things just sort of move where they shouldn't move because the connective tissue isn't holding it in place, then things just aren't talking to one another optimally and things don't work as well. And symptoms start to present, and all these symptoms, including headaches, by the way. So headaches with connective tissue. So if you think about the meninges, you know, it allows for cranial settling. It's like things just start to fall and the brain just move, even by millimeters. I mean, I'm not talking major shifts here, right? Even by a millimeter, it can change the way things function and you can have a headache. And so it doesn't mean that you have dementia or that you have any of these neurodegenerative disorders. So neurologists don't necessarily take it as seriously, but it means that something is not right. Something's not functioning as optimally as you want it to or as it should. And it's just because it moved slightly because the connective tissue wasn't holding it as well. So yeah, so all important. I feel like I just keep going off on these tangents, but I apologize.
Please don't apologize. This is really fantastic. We've been going about an hour and a half.
I know. I feel like I'm taking up everyone's Saturday.
Do you feel like answering any more questions or do you need to wrap it up?
I can answer a couple of more and then we can wrap it up. Yeah.
Um,
I know I probably talked longer than what I even expected. So maybe
it's been great. This is very, very useful information. There was a question. What's your experience treating intracranial hypotension?
Yeah, intracranial hypotension is notoriously difficult to treat. So if there is an identified leak, of course, then we want to patch it. Trying to find a leak can be hard. Myelograms is considered the gold standard, though they're often normal. So you need to go to someone who's really good at finding that shading difference, which is really what it. So I think some of you who have ever heard me speak, maybe had heard me say this. With connective tissue problems, there can be a discrete leak for sure, like a faucet. But what it normally is seepage, right? So because the connective tissue isn't taut and those meninges are connective tissue, it's just like it's seeping out, which is what creates the low pressure. So which is why myelograms are usually appear normal. But having said that, the seepage is sometimes greater in certain regions of the spine than others. And so there are, and I am not one of them to be fair, but there are neurointerventionalists that have become real adept at picking up that shadow that you can find that shows that there's a greater level of seepage in that particular region, and can notice and there are certain areas actually that are more susceptible to that. There's an area of the lumbar region, there's an area of the sacral region, there's a certain area of the cervical region. And it's like I said, it's a shadowing, it's a change of density on the MRI, or it's a change of, of intensity on the MRI or density of the CT. And they can pick it up, and you have to see one of them. If the CT myelogram is normal and there's a clear clinical suspicion of leakage that is creating the low pressure, but otherwise it's really hard to treat. And sometimes I just ask, surgeons to do blind blood patches, and occasionally even those that are not in this population and don't treat this population, just because I've asked and I've given them lots of reasons that they can't argue with why, they'll do it. And sometimes it's helpful and sometimes it's not. So then obviously bed rest is sometimes so if it's a true leak, it could resolve on its own, and people don't often recognize that. A dural leak can self-resolve. It can take a long time though. So bed rest is one of the things that we recommend. Caffeine and hydration, just to sort of improve volume and maintenance of volume while it's healing on its own. There's a medication that we've used over time. It's called theophylline. That neurologists might use for low intracranial pressure. I haven't seen it be all that successful for low. I will still try it just because, you run out of options and you just try to help patients as much as you can. But I work hard at trying to identify where there's leakage for sure. But yes, it could be a problem. And, those symptoms are if your headache improves when you lie down, of course, and worsens when you stand. Sometimes there's what's called where it's a later in the day headache. So it doesn't necessarily have to worsen as soon as you stand, but if you're going about your business and you're in the kitchen making yourself coffee or lunch, and then all of a sudden your headache starts, then that could be intracranial hypotension as well. It just took a little bit of time for the pressure to be low enough to cause the symptom. But with those kinds of headaches, you often see cranial settling. So, because it's also then there's cranial settling that also can be slow. And so then you develop symptoms sort of later in the day. So that's why symptoms, there's never any classic, medicine likes to put things in boxes. Like, these are the criteria. If it doesn't meet this, then it's not that. If it's A, then it's B. If it's C, then it's D. If not A, then G. So it's just but nothing is ever classic and nothing is ever typical in the MECFS population.
Okay, I'll give you this one last one.
Okay.
And then this is from the UK. We're also seeing certain portions of the NIH diagnosing kids with functional neurological disorder. But as a charity, we have concerns this may not be the appropriate diagnosis for many. And don't get me started on that one.
Yeah, this is a problem. I think it's an international problem. I know it's a big problem in the UK, but it's also a problem here as well. FND, its own body of research suggests that there is something behind some FND diagnoses in terms of the limbic system. I'm not yet ready to say that there's no such thing as FND, because I think that there is other reasons for a true FND diagnosis. But more often than not, it is of the MECFS class. And I realize that in the pediatric world, there's a lot of very scary things that are happening, and kids are being held away from the parents, and the parents are being held almost as criminals, from what I understand, for child neglect and child abuse. I don't have a great answer other than we just need to educate more, and we need to better understand these diagnoses. I personally think that the doctors I work with we have a real in-depth understanding of these diagnoses and what's going on. And you know, many of us are available to talk to any doctor who feels like they need to call Child Protective Services, really better helping with the case. And I know a couple of doctors that I work with are actually actively involved in working with CPS, that's chronic pain syndrome, with Child Protective Services, trying to better explain some of these diagnoses to avoid having these parents held in contempt. Yeah, we're trying to better these social problems that are related to these horrible diagnoses. And I don't really have a great answer to that other than acknowledging that it exists, but just giving hope that we're trying to make it better. I don't know if that answers the person's question or not.
I think it did. And she said, thank you. This, as you know, this is recorded, but there was a request. Is there a way that we could have a PDF of your slides that we could share? Okay, that would be great.
Should I send it to you, Melinda?
Yeah, that'd be great. Does anybody who's here have a burn? There's some questions still in the chat. Would anybody like to ask a question in person? I want to give you that opportunity.
I threw one into the chat. I don't know if you want to address or not. Have you ever encountered patients, or do you frequently encounter patients whose pulse pressure narrows, so systolic, diastolic pressures approach, that also are experiencing headache?
Yeah, oh, absolutely. I mean, that's part of dysautonomia. I mean, so as I've already said, like, it doesn't have to be POTS, right? So POTS is just, I think a lot of things present as POTS. I think POTS is, to be honest, I do think POTS is given too often as a diagnosis. I think there are other autonomic abnormalities, such as a narrowing pulse pressure, that contribute to headaches for sure. You know, when you know, the pulse pressure is an important parameter in terms of how we view how the heart fills and how it ejects appropriate volumes of blood, right? So when there's narrowing of the pulse pressure, there is an optimal filling and ejection, and which means that lots of organs aren't getting appropriate blood, but most specifically the brain, because the brain, from where the heart sits, and the brain, you know, the brain is the one that it has to go against gravity, right? So without enough volume and without enough pressure, if you remember the physics, then you're not going to have enough blood that's delivered to the brain. And you also won't have it with enough force to perfuse. I mean, and that's something that I didn't really get into, but perfusion is actually really important. And we think that there's, because of the low velocity that we know, again, now I'm once again going off your question, but because of the low velocity, there's also low perfusion. So the blood can get there, but if it's not perfusing in the parenchyma, then who cares, right? Because then the tissue isn't getting the oxygen and nutrients that it needs, and it's going to revolt with a headache, basically, for the most part, and cognitive decline. But yeah, so those kinds of parameters will tell us like how much blood the brain is getting. So it can definitely contribute to headaches.
So the treatment would be to address somehow to address the dysautonomia, because when I did my autonomic testing, I completely zeroed out. And the neurologist scratched his head and said, "I've never seen this before. I think it's a cardiac issue." And I said, "I don't think it's a cardiac issue."
I wish I was your neurologist.
I wish you were there too.
No, what it tells me is that it's dysautonomia, and it goes back to what I was saying about the vessels, which are part of the autonomic nervous system, right? They have receptors that they're the ones that know how to constrict, how to dilate, how to manage the volume and pressure of the fluid within your intravascular space. And so that tells me that there's a dysfunction in your vasculature, which is why your pulse pressure is zeroed out. And then therefore the ejection from your heart became less optimal, and therefore your brain didn't get enough blood. So that's a dysautonomia. And that is, again, the reason why I always say that it's not always just POTS. And autonomic testing is absolutely the appropriate thing to do. And I know autonomic testing is hard to find. Again, we have it here in Seattle, but it's very hard to find. And a lot of doctors are sending patients the link to the Bateman Center's NASA lean test, which I'm all about. I'm an advocate for, because it is a way that a patient can check for at least POTS on their own in their own home. And it's just a simple, free way to do it. So I'm all about it, but it doesn't tell you everything that we need to know about the autonomic nervous system is my point. And so when we can get autonomic testing, we should. And unfortunately, autonomic testing is also very expensive. So it's, it's one of these things where clinics can't really afford it. And yeah, so, but yes, that's a dysautonomia.
Thank you.
You're welcome.
When I saw my first ME specialist, which was over 20 years ago, I did tilt table testing, and I was diagnosed with neurally mediated hypotension. And that's one of the first things that he addressed to treat, which made a huge difference. So I agree with you that autonomic testing is really important. And
Absolutely.
And like you mentioned earlier, is usually that and mast cell, not back then, but now that and mast cell is usually the first thing that the specialist will try to tackle.
Yep, it's an easy place to tackle. You start with the low-hanging fruit. I think that's only fair to patients, to be honest, and as frustrating as it can be, because obviously treatment can be a lot of trial and error and a lot of, a long journey. The safest way is to start there, because there's a lot of toxic medications that we can use, but why start with toxic stuff if you can just start with some stabilization of mast cells, some improvement of, fluid volume balance,
Right.
which can really, again, make a huge difference in the symptoms.
Well, thank you so much
Oh, you're welcome.
for coming today.
There's another question from somebody here.
Oh, I'm sorry.
I wanted to let everybody know, I will do a survey of times if everybody's okay. We were going to shoot Dr. Ruhoy. We'd love to have you join us if you want to, but we're going to do a regroup next week, maybe, if that suits with everybody, and actually talk about PT/OT considerations that take your information into account. And so if people want to come with manual techniques in mind, specific products in mind, different communication tricks with patients to motivate and to educate, please come and join us. And like I said, I'll try to do a survey to find the best time for everybody, but also encourage, if you know other people in the group that have specific skills that are really effective with any of these aspects of what Dr. Ruhoy has talked about, we would love to have them join us. So
great.
Okay. Or if there aren't any other questions, I'm going to end the recording. And thank you again, Dr. Ruhoy. And
Oh,
we'd
you're
love
very
to have you
welcome.
back again.
No, I would love to come back. Yeah, there's obviously so much to say that I hope that at least what I said was clear and not too overwhelming. I know I tend to go off on tangents, and only because I guess I'm too passionate about this stuff. But that's what I've been told.
We're passionate too. So
I know, which is why I like talking to groups like yours, because I speak at a lot of neurology conferences, and the room is like their eyes glaze. But that's not fair. That's not completely true. But a lot of them are like, it's just too much for them. They don't have a lot of time in their practices. And I get it. This takes a lot of time with patients. It takes a lot of thought and a lot of learning something outside the box, which we're not used to and most are not comfortable with. And so, but I love talking to groups like yours, because I feel like we're all on the same page, right? We all know it. We get it. So it's great.
Yeah. Well, thank you guys. Thanks everybody for attending.
Everyone. Have a great weekend.
Recording up at some point. Thanks
and I'll
a lot.
send you the PDF of my slides, Melinda.
Okay. All right.
Okay.
Thank you.
Bye-bye.
Bye-bye.